Hello for everybody that is tuning into us now. We are going to be launching into our 6th installment of the PhenoTips Speaker Series. So welcome as everybody filters in. See, the numbers are climbing. Hope everybody's off to a good start to their day or afternoon, depending where you are in the world joining us today. For those that aren't familiar with our PhenoTips Speaker Series, we've been hosting this since the summer as part of the pandemic, just being able to connect with people throughout the world so that we can continue our education and continue connecting with each other and learning from each other. So happy to see people joining into the live stream right now. I'm your host, Kira Deneen, and today we're going to be talking about the adoption and outcome of digital tools in clinical genetics. And our special guest is a digital champion, Dr. Charles Shaw-Smith. He is a clinical geneticist at Royal Devon in NHS. Thank you for joining us, everybody that's filtering in. We appreciate you joining us today as we talk about the adoption and outcome of digital tools in clinical genetics. We have a lot of questions that I want to have answered by Dr. Shaw-Smith because he is certainly an expert in this field. So for people that aren't familiar with our format of the show here, we're going to be doing a 40-minute interview. So just me and Dr. Shaw-Smith talking about these topics of adoption and outcome of the digital tools in clinical genetics. And then we're going to have questions from you in the audience. So throughout the webinar today, you can put your questions into the Q&A box. So that's that bottom option in your Zoom right now. So if you have questions, feel free to pop them in throughout our conversation. Then at the end, we're going to answer those questions. So if you see a question that you're like, I really want this to be answered, certainly vote for that to be higher up on the list, and we'll go through that. So feel free to be submitting that. Even if you have questions now, you can certainly start adding to that. So for those that aren't familiar with PhenoTips, I wanted to mention that they are the sponsor of this speaker series. They're the world's first genomic health record system. They have software and services that ease genetic professionals' workflow. Tools include pedigree builders, standardized symptom capture, and diagnostic insights. Many of us that work in the field know that electronic health records are not built for genetics. So PhenoTips is filling in this gap for us by providing a complete suite for genetic medicine. So again, in light of the pandemic, PhenoTips has sponsored this series so that we can continue having these conversations and, improve our workflow, especially with digital tools. So as I mentioned, I'm Kira Deneen, your host for this webinar. I'm also the host of DNA Today, which is a genetics podcast and radio show. Last year, we won the People's Choice Podcast Award for the best 2020 Science and Medicine podcast. So we're really excited to have that. And if you find conversation today or any of the other webinars interesting, you could check out the show. It has over 140 episodes in the last 9 years. So, and I'm also a prenatal genetic counselor, so recently joined the field there. And as I mentioned, our guest today with us is Dr. Charles Shaw-Smith. He is a clinical geneticist at Royal Devon NHS for the last 10 years. He has an extensive research background, over 75 papers that focus on 2 main areas: chromosomal disorders of childhood and genetic causes of congenital malformations, specifically focusing on the GI tract. And one of the reasons we have him on for this installment of PhenoTips Speaker Series is because of his interest in electronic patient records and digital tools. So thank you so much, Dr. Shaw-Smith, for coming on the show today and being able to connect with all of us and share your insight.
My pleasure. Thank you for the invite.
So I thought we could start our conversation talking about how the pandemic has changed the scope of digital tools and what changes you've seen in the last year or so as we've all been adapting, and a lot of us suddenly adapting to using more digital tools.
Interesting question. It's been an extraordinary year in our service. So we spent a couple of years leading up to a go live of a full electronic patient record in our hospital trust, which was provided by Epic, which is of course an American company. And as they do with all hospitals in which they help to install electronic patient records, a lot of preparation went into that. And our go live date was set for June 2020. But of course, in February 2020, or February, March time, the pandemic started, and there was some. There was some. I wasn't personally involved, but there were some very difficult discussions in the trust about what to do, and they just looking at all the data and all the possible options. It was decided to put the date back to October 2020, and alongside this, the trust also was in the process of taking the decision to switch to using a voice recognition software system for dictation of letters and other clinical notes. So we've had those, and we did go live in October 2020. And I, as you said, I am something of a digital champion. So maybe my my opinion should be taken with a pinch of salt. But I'm delighted with it. It does present, as you said, some very particular issues with clinical genetics. I'll be very happy to talk about some of those. But overall, there have been no major disasters. I think it's been a successful rollout. The voice recognition has worked. And of course, alongside all of that, there's been impact on the way we run our service because of the pandemic. And we've been doing, as elsewhere, a lot of our consults have been switched to telephone or video consult. So it's been a really extraordinary year. But we're still here providing genetic services in Devon and Cornwall.
Yeah, certainly. I mean, pandemic has changed a lot for so many people, and knowing that it sounds like you already had those plans in place before the pandemic happened, that you were looking to switch to those digital tools. And so it just got switched a little bit in terms of, delayed in terms of rolling it out. But just with the experience of that, any tips or advice of just going through that for people that are looking to do the same in their healthcare systems?
Yes, so about a year in advance of the go live date, so more than a year actually, probably about February, March 2019, we set up a steering group within our department. And that steering group had representation from all the stakeholders in the department, including the consultants, the genetic counselors, and the admin. The admin team, absolutely critical in this, because the admin is so complex for all our appointments. And we held monthly meetings, and we tried to plan ahead as best we could and to anticipate difficulties. And for example, one thing that actually went reasonably well, I think because we anticipated the issue and tried to plan for it, was the simple fact that within our service, we do outreach clinics in really quite a large number of peripheral hospitals. So maybe 20, 25 hospitals, some of which are very small cottage hospital type affairs in Devon and Cornwall, which is the region that we serve. Cornwall, you'll note, is hosting Joe Biden in June for the G7 summit. I don't know if you noted that. So it's going to be famous.
That is certainly a timely thing to mention today, yes.
What we were worried about was whether we'd have access to Wi-Fi, something as simple as that, because those peripheral hospitals don't necessarily provide you with connection to the internet on your own hardware. So through a variety of means, we had to ensure that we'd have Wi-Fi access in all of these places, and we just about managed that. But it took a huge amount of advanced planning and visits by me to a lot of these peripheral hospitals in the lead up to the go live. But in terms of preparation,
yeah.
I think a steering group with good representation and regular meetings, I would say, helped us enormously, and I'd strongly recommend anyone else to do the same.
Yeah, to have people involved from multiple departments, and especially as you mentioned with the administrative side, that is so hugely important, because how everything is structured and is really going to do with using digital tools. Are there areas of clinical genetics that you see being replaced by digital tools? I'm thinking of the chatbots now available, video reviews, result portals. Do you see any of this really just swing over to be completely with digital tools?
Sorry, Kira, could you just repeat that? I lost you a bit for a second.
Sure. So just looking at what areas of clinical could be replaced by digital tools about the chatbots, video over result portal.
Yeah, those are good ones.
Just go digital.
Yeah, you're breaking up a bit, Kira. So maybe put a couple of thoughts in the chat. One thing, you know, obviously that's pertinent to our hosts for this is pedigrees, drawing family trees. And that's something that I've been interested in for quite a long time. We had a very unsatisfactory hybrid system of electronic records and paper records for our pedigrees. So we have used a system called TrackGene, which is as an Australian company that provides services in that specific area, pedigree drawing with a few add-ons. And we did look at PhenoTips actually, but so far because we've historically used TrackGene, we're trying to stick with that. The other interesting point about all of that is that Epic do also provide a pedigree drawing tool. We looked at that quite carefully with them, and we felt, for reasons I'd be happy to discuss later, it wasn't suitable for us. So we're now embarking on a piece of work which I'm excited about, which is to formulate a group of stakeholders, which includes representation from Epic, from TrackGene, from our own service, and from our hospital IT department, to try to make the interface between TrackGene and Epic more seamless. And we feel that that is something that we can very usefully do, and it will really improve the way that we work. So Kira, you mentioned a couple of other digital tools. So we use video software for our patient appointments, and you know, we have discussed, and I'm sure other places have discussed, and we don't have any special expertise in this, but clearly, you know, especially with distances involved to some of our patients, you know, we are looking to explore the potential for replacement of face-to-face consults with some online ones. That said, I really, at this point, feel a lot of sympathy for my genetic counselor colleagues, because the decision was taken in our service that they would, because the type of consult that they do perhaps lends itself a bit more to online and not face-to-face, simply because they don't usually carry out physical examinations. They have essentially suspended their face-to-face service and are doing everything online. But the feedback that I'm getting from that is that they're not very happy with it. They don't like it. And you know, some people have hinted that, some of our genetic counselors have hinted that if it stays like that, they're not sure they want to carry on. And yeah, it'd be interesting to hear what other thoughts other people have about that.
Yeah, it's certainly different from my experience counseling patients, you know, through a platform like this, where we're just seeing each other over video chat. And I think one of the big parts of that is just their concentration during the session. You know, something I found is, if, you know, I work in prenatal, sometimes there's something that's more challenging, and just being able to have the psychosocial part is really challenging.
Yeah.
I think if you're looking to connect with patients and, you know, being able to, you know, work on that in terms of the information, you can get the information across, but it's more of the human side of it that's certainly more difficult. Just looking at how we're, you know, shifting over for a lot of things becoming more digital, have you seen that there's a difference in error rates and accuracy between, you know, our old school using paper and now with this digital? Is there a difference there?
Yeah, that's a good question. And it's actually at this point a bit difficult to answer, because we're still within the first 3 months of go live. And, you know, there are always going to be errors and mistakes during that time period, and we just need it to bed down a bit. You know, I think we've avoided any really, for the most part, any really serious errors. There was one which was actually, I think, more down to human error than down to any issue with the electronic patient record. For me, it's very interesting to go from effectively a paper-only service, which is still the case for quite a few services in the UK. I don't know about the US, maybe fewer, but to switch over entirely to an electronic system is definitely bringing changes. And really, it's too difficult to answer that question right now. I mean, one thing I could perhaps highlight, which is relevant to people, I think maybe more in the UK, is that the genetic record, the record that we previously kept, that was a paper record, was in fact a family file. And it was, I mean, some of these things are huge lever arch files with hundreds of pages and you know, maybe a couple of dozen sections for different individuals within that family file, right? And of course, there's a massive cultural shift to go from that to essentially using a single electronic patient record. Now, what we've tried to do is to link family members by assigning a specific family number to relatives within the same family, so that we can pull out all the members of that family who have the same record, who are part of the same family. We can look at them. But it's really very different. It's a very different way of working now, and we have quite a lot of debate about what information that previously we were happy to write in a family file, we now would consider writing in an individual patient file, which is not exclusive to our own service, but is now visible to every other clinician working in our hospital. It's a huge cultural change, and we're still getting to grips with it. I see there's someone from Great Ormond Street Hospital in London, and you know, the GOS have got more experience of this than we have, and I know they've grappled with the same issue.
Yeah, certainly we're in a unique area of medicine where we don't just have information on the patient, but rather an entire family when it comes to gathering that family health history information.
Yeah.
So it's interesting to see how that is going to play a role in terms of how we're putting that into a digital form and keeping it attached to that patient, but also protecting the privacy of other family members. So the way you're doing it, from what I'm understanding, is you're assigning a number to the family in general, and then that number follows people in their individual medical charts.
Yeah, that's right. That's right. But the issue is perhaps also more to do with the fact that, and I must admit, I've always found this unsatisfactory, is that because we keep our own, or we previously kept our own paper records, which were never seen by anyone else outside our service, outside clinical genetics, we were really quite insulated from the rest of the hospital. And you know, and increasingly there are tensions there, for example, with cardiologists running joint cardiology genetics meetings, cancer services wanting to know information about the genetic risk for the patients that they see. I mean, of course, you know, we communicate with these people, we write letters to them, we've always done that, and that, you know, that continues. But certainly some initial feedback is that, for me, I think, is that first of all, communication with other specialists within our hospital has improved a lot using Epic. So we're able to discuss patients within the record. That was previously done by email, and we were referring to our own paper notes, and they were referring to their paper notes, and there wasn't a great deal of meeting in the middle. I think that is a huge improvement. But this.
And so within Epic, yeah, sorry, go ahead.
No, that's fine. Can you ask your question?
So I was just wondering, so within Epic, because that's also, you know, a software that a lot of people in America use as well, in terms of, medical information. How does the pedigree tool look like in there? How are you using that?
Well, yeah, that's a good question. And in fact, in our meetings with Epic in the lead up, we had several meetings where their pedigree tool was demonstrated to us. And those people who use Epic will be aware that there are certain parts of the Epic record that they mandate are visible to anyone who wishes, any clinical person or who's entitled to look in the record are visible to everyone. And that's things like past medical history, drug history, and so on. And the issue for us was that we put information on those pedigrees that is really quite personal to named relatives, but is not something that we feel just through patient confidentiality we can put into an individual record. I mean, you can see that it poses a real difficulty, and we looked at it and felt that it wasn't going to be acceptable, and that is why. And it's for the same reason. Or I mean, actually, their pedigree drawing software is a relatively new feature that I think was not available when other UK genetic services were looking at it. But I think we were the first to have the opportunity to look at it, and we felt really for that reason it wasn't going to work. And we asked them if we could make the pedigree, we could have a version of the pedigree that was private to our service, which I thought was a reasonable request. But
certainly, yeah.
When you're dealing with these people, you quickly learn that there are some issues on which you are not going to make any progress whatsoever, and that was one of them. There was no chance of getting a sort of bespoke version of their pedigree that would be just for our service, and that's why we had to look elsewhere.
Yeah, that's a good thing to highlight in terms of what people should be looking at for pedigree drawing tools to see what their requirements are, and then what tools that are out there are going to meet those requirements. So for you guys, customizing who had access to this was a deal breaker. What are some other aspects that healthcare providers should be looking at in terms of what their pedigree drawing software should include? What would be your top few features?
Yeah, well, I think the first thing to say is that because of the issue I've just mentioned, you are going to need to use an external pedigree drawing software, okay? Because you can't use the internal Epic one. So the next question that immediately comes up is, what is the degree of interface between that pedigree tool and Epic that you can have? Because clearly you want there to be some interface. You don't want them to be completely separate. I mean, for example, in the ideal world, you would have a situation where you'd have the pedigree in the pedigree drawing software open in front of you, and it would be live. So you would click on an individual in that pedigree, and if there was an Epic record for that individual, it would take you straight to it. And that is on my wish list for the work that we're going to be doing with TrackGene. The other thing is that you want some flexibility in terms of how much data or information you can put in under each individual on the pedigree. So, particularly say with the cancer ones, you want to be able to specify the precise cancer diagnosis and the age of diagnosis and various other things. And depending on the condition that you're talking about, you almost need a free text box that you can add information to. And that, I mentioned that because that is not available in the pedigree software that we're currently using. And I think it's something that needs to be. So I think those are some thoughts about what you need there. Yeah.
Yeah, I think those are good ones to think through. And it's really going to depend on what specialty you're in. As you said, those would be aspects for cancer and pediatric, being able to put in all developmental milestones or different areas there that, when we're drawing a pedigree, we're writing in a lot of extra information.
You do, but I think you also, I think most of us would say that when we're, let's say we are taking a pedigree in a, let's say a developmental condition which is heritable, so there might be other affected individuals, that you've got a choice between writing a lot of stuff on the pedigree or writing it as part of a clinical note. And I think traditionally a lot of us have tended to have a sort of family history section within the clinical note and documented quite a lot of stuff there. So I think you can overburden the pedigree with too much detail and perhaps lose a little bit of the visual usefulness of it if you do that. But there is a balance to be struck there for sure, yeah.
Yeah, and I think another aspect that I'm looking at in terms of digitizing pedigrees is the ability to speed up research. I mean, how have you seen this in the field now that we have more pedigrees that are in this digital form? How do you see this impacting research, either that you've already seen or that you foresee in the near future?
Yeah, well, I should first of all say I'm not so research active now. I've found all this digital stuff to be fairly consuming, and that's what I'm mainly focused on at the moment. I think the other issue about pedigrees and research is that, and you know, we had a query about this recently in our department from an ENT researcher who was conducting research on thyroid cancer, and he was wanting us to share pedigree information. And you know, clearly a major issue is what information you're permitted to share, and it's, you know, it's totally dependent on you know, the consent form that was signed at the time that the patient was signed up to the research project. And often, maybe usually, unless it's a fairly unusual project, really nothing is said about what can be collected in terms of family history for a given research project. So I guess maybe just a useful feature for a pedigree is to be able to completely anonymize it, so that which most pedigree drawing softwares will do, so that you can perhaps share some information on an anonymized basis. But you know, this is a bit of a minefield in the research area, because you can come up against that question of the confidentiality of the medical information of the relatives of the patient who's been recruited.
So it seems like we almost need to start from the beginning and include this more in consent forms so that it's more standardized, that your medical history information can be shared with research so that you are covered and able to do that, which is going to take some time to do, but I imagine that will be one of the first steps in order to achieve this.
It's true. I mean, most of the research projects that I was ever involved in really focused on a given individual and didn't delve too much into their family history. And we had something in the UK called the 100,000 Genomes Project, which was a little bit of a mix of clinical genetic testing, and it had elements of research. And that, interestingly, that did involve collecting multiple individuals from the same family, but of course they were very carefully individually consented, right? So each person so you might have 4 or 5 individuals, each with the same condition within the same family or extended family. They were recruited to that project, but quite rightly, anyone who was, you know, participating, and of course it involved giving samples, so you know, you had to consent each individual. I think, you know, this whole idea of, you know, the family history in research is a difficult one, and the safest territory to be on is, if you want to delve further into the family, you just have to be specific and state which family member you're interested in and recruit them as well.
And that ends up being quite time consuming, because you're not just doing a blanket statement that, I mean, to get all that information and all of the consent, that is a lot of, you know, someone's time in the healthcare field.
It is, and actually, you've just reminded me that, you know, that whole issue nearly broke the database system within the 100,000 Genomes Project, because they ended up trying to recruit individuals from the same family who were geographically in very different parts of the country. And for some reason, the IT infrastructure just couldn't deal with that. It was horrendous. It was absolutely horrendous. And we had to design various workarounds to help us get there, but it was very time consuming.
And another aspect of this is patients having access to information. And, with this being in a more digital form of patients wanting to say, well, I'd like access to my medical chart.
Yeah.
How do you see this playing a role? I mean, what ways do you see patients being able to access, or is there going to be areas where we say, this is too much information, or, now they're accessing notes that are going between doctors? I mean, how do you see this being filtered and patients actually being able to access their information?
Well, maybe you won't be surprised that in fact, I'm a clear outlier in my own service for making information available to as much information as possible available to patients and consulting them wherever we can. There's a nice feature in Epic is a patient portal, which we're still getting to grips with using actually, but it's called My Chart, I think, and it's the patients are signed up to it quite straightforwardly by receiving a text message or an email, and then they have a presence within their own record. But of course, they can't see everything within the record. And essentially, my understanding is that you can place items from within the patient record into that portal, and it saves, because we still send out a lot of letters by post, and it really surprises me how much paper we're still generating. But obviously, patients on that portal, it's immediate. And it doesn't cost anything, and it's highly convenient for the patients. A lot of them, I'm sure the younger ones don't really want to get paper anyway. They'd be much happier getting stuff electronically. So I see that as a very good feature. And one thing that I would love to see in that, again, we send out paper to patients to ask them to write down the information that, this blows my mind that we do this. So we have a big form, and it's got, who are your parents, who are your brothers, who are your sisters, and we send it out in the post, and then they fill it all out. These are all my relatives. And then they send the paper version back to us, and we employ people in our department, more than one person, to get that information off the paper and into the electronic pedigree. Whereas surely, it should be possible to design a form within the patient portal, which they fill out and which will generate the pedigree within the pedigree drawing software without the need for an intermediary. And, talking about errors, that team of people who do that transcribing do make errors, sometimes quite embarrassing ones, like incorrect assignment of gender, or incorrect assignment of whether they're alive or deceased. And if you've got this pedigree in front of you and you mention that and they say, no, that's wrong, and it's been incorrectly copied from the form, it is not a good look. And yeah, I do feel strongly about this, as you can probably tell.
Yeah, I mean, and it's such a waste of time to have people write it and then reading handwriting. I mean, it feels like, is this 2021 or not? And yeah. It's great. PhenoTips does have this feature where patients can answer a questionnaire ahead of time so that you have that information in a digital format. And I mean, there's so many errors that can happen along the way, as you mentioned. So it's something that, I would expect we're going to be moving forward to, but I mean, it takes time to adopt this, but certainly it's like the technology's there and it's just being able to get that into motion.
I know PhenoTips have, and that was, we as I say, we did look at PhenoTips, and they are, I've discussed this with your CEO of PhenoTips, I can't just think of his name. I know he's very keen on that, and rightly so.
Yeah, certainly. And I think the other thing you mentioned before was just patients having access to their medical information of, getting records and information like that, how much time do we spend, patients asking an institution, can you send my medical records to this place?
Yeah.
Whereas if they can have
Yeah.
access themselves, they can download it, send it as they so wish. One area that, I find that's interesting, even for me practicing, is, patients having access to different portals through genetic testing and different companies that I'm ordering from, that getting portals directly from them and setting up that I'm contacting them with their results before they're getting it from that company. So is that something that, with an Epic, are patients getting their information directly from their healthcare provider in terms of results, or are they able to see those results ahead of time? Do you know how that workflow is?
Well, the patients are completely reliant on the genetic counselor or the clinician who ordered the test to feed that test result back to them. And it's carried out, all the tests are carried out through a network of NHS testing laboratories. And that may not be exactly the same in the States. I dare say you use quite a number of private providers, and possibly
Correct.
Patients can communicate directly with them. Is that how it goes?
Yes. So there's a lot of different, they can access the company, they can access their healthcare provider. So certainly it's a different setup. Yeah.
Right. That's
interesting how different it is, right?
That's a very alien concept to me. I mean,
yeah.
I have to stop and think about that for a second.
Yeah.
We kind of guard this genetic, we maybe overguard this genetic information that we get, so there is no prospect whatsoever of a UK clinical genetics patient contacting a laboratory and getting them to part with any genetic information about them. They will always say that it has to go back to them via their genetic counselor or geneticist.
Yeah. Yeah. And just a quick note how, in terms of like my experience of genetic counselors can set up their accounts differently. So if they say it's a low risk negative result that's happening, that automatically gets released 48 hours later. So for me, I can contact the patient within that 48 hours so that they're hearing from me first before they have the results. And then anything that's abnormal, obviously, is not going to be sent to the patient. I need to personally release that. So okay. I don't know how, I can't speak for everybody, but in terms of me working in outside of New York City in the prenatal space, that's kind of how we have it set up. But it's certainly interesting to see if that's going to shift, and just in terms of giving results and having that information of, how involved are healthcare providers like going to be in the future?
I mean, I know that what all my colleagues would say would be that, we're there to provide interpretation of the test result. And that is not necessarily immediately apparent from, the formal report that the gives out. I mean, I've seen some reports from the US, and they can run to a number of pages.
Oh, it's much longer than sometimes I think it needs to be. Yes.
So that's hard for the patients, isn't it?
It is. It's not always in plain English. Like, we're reading through and like trying to figure out, okay, like let's look at this percent here. Oh, that's what that means. And yeah, certainly.
Yeah.
Yeah. Another area I wanted to pick your brain on was what other areas of genetics that you see digital tools being used in terms of risk models. So that's kind of going back to, we were talking about cancer earlier. There's a lot of risk models in terms of the risk for someone to develop cancer. And there's been a lot that have been developed. Do you see this evolving more so now that we're in this digital tool era, and maybe expanding into other areas of genetics and not just focused on the cancer side?
Yeah, that's a good question, and I'm not best placed to answer that. I'm sorry. I know I'm a little bit of an outsider to the cancer genetics field. I do relatively little of that, but it's always struck me as strange that there isn't a kind of uniform approach to risk models. Some departments will use models such as one that we have in the UK called Bodicea. Mm-hmm. There's a Manchester scoring system that's used. Other departments tend not to use them, and and then the other side to this is the polygenic risk score prediction models as well, which are still, I would say, regarded with some suspicion and as controversial in the UK. So there's been no widespread uptake of those as yet.
Yeah, I'm looking forward to seeing how that's going to evolve as well, because we're such at an infancy point with polygenic risk scores that I imagine
Yeah,
that's going to get much better in the next 5-10 years.
I agree, and I think it's fascinating, and I think again we should embrace it. Anything that can inform someone's risk of getting breast cancer, say, is going to be useful. Yeah.
And are there any other recent additions to digital tools that we haven't talked about that you've either used personally or seen really helping in terms of clinical genetics and people working in the field?
I guess I just mentioned in passing about it's not really a genetic specific tool, but voice recognition I think is very powerful, and there are a lot of efficiencies there that we can draw on to help us. The other thing in the clinical setting, digital photography. There's a very slick app available within Epic whereby we take photos of some of the pediatric cases that are referred to us. It is remarkable. You open the app on your phone, open the patient within the app, take a photo of the patient. You get all the consent and everything, and it goes straight into the record. And what's interesting, and there's been a lot of debate about this, which I do think is fascinating. So the photo does not go onto your phone. It completely bypasses the phone and goes straight into the Epic record. But people, I think, have been rightly concerned to think that patients will see you taking photos on your phone and think that you're going to be walking around with the photo of their child on your phone, even if you explain it to them. And some of my colleagues have just expressed the idea that some people will, again, understandably be nervous about all of this just because, it's a digital photo that's going somewhere. They don't really know where. It's a difficult area because, digital photography and the internet has sometimes, created issues.
Yeah, certainly. I think that's one area of just protecting patients' data and having them understand exactly what's going to be used with it. And
Yeah.
obviously, there's been a lot of data breaches over the years, and
Yeah.
even with some genetic testing companies. And so I think that's one that is on people's minds in terms of, okay, well, you're saying it's secure. How secure is
Yeah.
it? What are these conversations looking like with patients in terms of explaining to them those security features and just what we do have in place?
Well, I've had conversations with patients about it, and it's funny because I report my experience in our weekly departmental meeting with all of my colleagues, and someone else will supposedly be reporting the same thing, but with quite a different slant on it, which often seems to be a slant that goes with their take on it. So my feeling is that when I explain it to the patient, they understand it, and they understand that the medical electronic record is confidential, and it's the photograph will not go outside that record under any circumstances without their permission. Then I have a colleague who has perhaps a naturally greater suspicion about all of this stuff, who will report that some of his patients that he've explained it to are suspicious of it and are reluctant to give their consent to have it done. So, I mean, clearly there is going to be variation in the way people respond, and maybe, younger people who use Instagram and Facebook and all the rest of it all the time maybe are not going to be, they seem to take photos of it. My kids, they just take photos of each other and put them on Snapchat or something all the time.
Yeah. They don't even think about it most of the time. Yeah.
They don't. So it's strange. There's a lot of variation in views out there.
Yeah. And I just wanted to take a moment for people that are tuning in live. If you have questions for Dr. Shaw-Smith, certainly put them in the Q&A feature at the bottom of your Zoom there. And we're going to get to those in just a couple minutes. I have a couple other questions that I wanted to ask him before we do that. So before we get to our, viewer and listener questions, what are your advice for genetic departments that are looking to adopt digital tools? What are the first steps? We kind of talked about, at the beginning of the recording here of your experience of, in 2020, switching over and using a lot of digital tools. From that experience, and for people that are tuning in to figure out those first steps, what is your advice? What would those first few steps be?
Okay. So, clearly what we've been through is a massive change, going from a completely paper-based, family-based system to a completely electronic, individual patient-based system. And as I said earlier, that requires a lot of planning. That is a very, very big, it's a massive cultural change. I can't quite believe that we've survived it, actually. It needed a lot.
It's a huge undertaking.
It was a lot of work, a lot of preparation, and a lot of meetings, and a lot of trying to resolve conflicts, within the department about what people felt about certain things. I mean, one example I've not even mentioned is, with this move from a family record to an individual record, we were very concerned about confidentiality. And there's a feature within Epic called Break the Glass, where if you go into, let's say, a patient within the hospital has got a set of genetic records, anything that's attached to that genetic record, any clinician from outside our service who wants to go into it gets an alert, a warning that says you're not allowed to go into this unless you can make a case, and your going into it will have been audit trailed, so we know who you are. And it's that system is in place, and it's really unsatisfactory for lots of reasons. Anyway, I got sidetracked there, sorry, but I did want to mention that because it just illustrates, it just illustrates the pitfalls.
Yeah, definitely. So I wanted to get to one of our listener questions here. What is your view on storing patient data in the cloud? Do you think it's inevitable that all patient data will eventually be stored in the cloud as opposed to the hospital?
It is cloud-based. And I know PhenoTips have cloud-based servers for their information. And I know from conversations with PhenoTips that is considered to be more efficient and as secure, although I'm by no means an expert in that. But and again, I'm not an expert in data breaches either. But I know that no system of this kind can be considered to be invulnerable to being hacked into. And I know some hospital electronic record systems, including in the US, have been hacked into, and causes an immense amount of trouble. But that's not my pay grade to think about that kind of stuff.
Yeah, and we have another question that's kind of along similar lines. What is your view on the statement, no medical information is completely secure? And I think you kind of just answered that of saying that we really can't say anything is secure, I think, but there's certainly different levels to it.
I just think we are storing up potential enormous vulnerability with this way of working. And I know there's been, I read about a data breach in the US recently that was quite far-reaching. I can't remember the name of the company, but the point was that it was a company that provided IT services across a broad range of industry, including hospitals and hospital electronic records. And I know there are experts who have sounded warnings about this, and we are vulnerable to it. And we just need, well-informed, clever people on our side to plan for such breaches, because they will happen.
Yeah, and protecting information, even when it's being stored, to have ways that it's, patient names are not exactly with it. There's, different numbers assigned to it, and looking at different ways that we can protect that information. I wanted to read another one that's not necessarily a question, but just a comment, a remark about the pedigree digitalizing within Epic. This person says, in the 5 years experience with genetics and Epic, it appeared that several months after introducing Epic and a sophisticated pedigree software tool attached to it, which I think is what you were talking about earlier, people referred to drawing a pedigree on a blank page and dating it, having it scanned into Epic, and then the next consultation, it was printed out, updated, and then scanned in again, 100%, 100 times less complicated and expensive, and it worked well. What are your thoughts in terms of people that are doing it this way? Is this a good way to get around it? I mean, it's not quite a digital pedigree. It's somewhere in the middle there.
I fully understand anyone who would rather have a sheet of paper with a pedigree on it in front of them in the clinic. It's easier. What I don't know is that if that just reflects, the long-term practice of people like me. I suspect that a person who'd never been used to drawing pedigrees on paper, but was brought up using electronic pedigrees would be fine. And the only issue with I think the TrackGene pedigree tool is okay, and I'd be happy to use it in the clinic. The problem we're trying to fix at the moment is it's just so slow when you use it outside the hospital, and we really want to fix that. So there's some really interesting issues there, but paper pedigrees they're fine, really.
Yeah, and I would definitely recommend people to check out the PhenoTips one, because it is very quick and easy to use.
It is easy
especially
to use,
yeah, for some people, in other webinars that we've talked to people and they ask, well, is it going to be as quick? I'm not used to doing that. Give it a couple goes with just like a family you have in your head, either from media or book series you're reading or movies or something, and go through and do it, and you'll see how easy it is and intuitive to use. So I think it's worth trying out a couple times, and maybe trying it with a patient and seeing how it is. We have another question submitted. It says, are you familiar with Invitae for drawing pedigrees? How does that compare to PhenoTips and the Australian one you've mentioned?
I missed the name. What was it?
The Invitae drawing pedigrees, and
I'm not
just
familiar with that.
seeing
Sorry.
if you're familiar with that.
Invitae, yeah.
Yeah, I feel like I've used this one before, and I can't quite recall exactly how it worked or how it compares
the name is,
to PhenoTips.
I've come across it. I've not used it. I think to give in terms of a comparison between PhenoTips and TrackGene, I would say simply that PhenoTips is much slicker, but it is a lot more expensive as well. Probably for that reason.
Yeah, so certainly a lot of things to compare, and seeing, what other features are included, because everything's going to be a little bit different. Not only just like how you're using it, but PhenoTips having like the symptom capture and, other tools with that. So
one thing about PhenoTips that I'm not sure what they feel about this, but you sometimes get the impression that they are trying to set PhenoTips up as a complete electronic record for patient records, whereas I think probably most clinicians like me would not expect that. And of course, we, as I've emphasized throughout this, what we want is good communication with clinical colleagues throughout the rest of the hospital. And so you are stuck with using the system that all the other specialties in your hospital are using. You've got to go with that. You can't sort of go it alone. Otherwise you end up with the kind of silo system that I was talking about before, where there's just not good communication because you're using different records. And I would never advocate that. I think, it's really, there are many advantages to better integration with the specialists outside clinical genetics within your hospital. I mean, another discussion that we've had is, so when we have MDTs, we discuss a variant of uncertain significance, say, and we just don't know whether it's the cause of the phenotype or not. And we sort of have a discussion with colleagues. Some of my, and I mean colleagues from the laboratory and maybe from an outside specialty as well, some of my colleagues felt really strongly that that sort of discussion should be hidden from view because it was potentially dangerous, because people would misinterpret or get wrong or take information out of it that they shouldn't have done, or that was incorrectly interpreted. I disagree with that. I think, let's be open about these meetings that we're having. Let's try and educate people out there. because we spend a lot of time complaining about how ignorant people are about genetics who are not geneticists. And we should be doing everything we can to educate them, in my view. Just a little bit of soapbox there.
And if patients have questions, then it's like they can ask their healthcare provider and be more engaged in, their own healthcare. So I agree with you on that. I think, letting patients know about, VUSs and so that they can also track it.
Well, yeah, I wasn't talking about patients then. I was talking about non-genetic specialists like pediatricians or cardiologists. I mean, that's a whole different question about whether you'd want a patient to be privy to an MDT discussion about their variant. I mean, in terms of patient-centered care, I think there's a guy in the States or Canada who's really huge on this, and I read one of his pieces. I just love everything he says. We need to be sharing more stuff with the patient, not less, and we need to view the record as the patient's record, not our record. It's their information. And the idea that we would sort of jealously guard them from looking at it just feels all wrong to me. But yeah. Anyway, I know not everyone agrees with that.
I think we're on the same page there, but yeah, we have time for one more question before we sign off. This question reads, I'm aware of an app that can be used for pedigree drawing where a patient is prompted to download an app, input family history, and then this is sent to the GC and a pedigree is automatically drawn, which also PhenoTips does that. So maybe they're referring to something else. So they asked, any thoughts on this for future use in clinical genetics?
It's what we should be doing. We absolutely should be doing it. And we need a robust system that will enable us to do that. And it will save it, well, for all the reasons I outlined earlier, it would just be better.
I think years from now, someone's going to watch this back and be like, wait, we didn't used to do that before. And it's going to be like standard for people.
Yeah, that's true. But from where we are now, that's actually quite a big ask to do that. The technology somehow doesn't feel like it's quite there yet. But it should be in the future for sure. Yeah,
definitely. Well, thank you for everybody that is tuning in. Thank you for, joining us today. Dr. Shaw-Smith, thank you so much for just bestowing so much information and letting me pick your brain about all these topics. It's just such a treat to be able to hear all your insight today. So really appreciate you coming on.
My pleasure. Thanks again. Thanks for the invite.
And for everybody, you will see a feedback link emailed to you. Please take a minute to offer your feedback for today's webinar. And you can also pick topics that you'd like to see in upcoming series. The email will also include a link to the PhenoTips Speaker Series page where you can sign up to receive alerts on upcoming sessions. Our next webinar is going to be in February, and the topic is improving patient experience. So if you also have not signed up for that, you can go to phenotips.com, click the stories tab, and then the speaker series is going to pop up on the drop-down menu. You can view all our installments there from last year and all the ones so far for this year. So definitely check that out, phenotips.com. If you've enjoyed this conversation, you may also like my podcast. Search DNA Today on social media and podcast players, or just go to dnapodcast.com. And Dr. Shaw-Smith, do you want to include your website for people to learn more about digital tools in genetics?
Yeah, I did write a blog for a few years, but I've not added to it, and I do plan to add to it. So I'm happy for you to add it on the understanding that there's some not very up-to-date stuff there. I've got quite a few ones that I'd like to add to it in the future. So there we go.
All right, sounds good. And we'll make sure to include all the links that we've mentioned today in the blog post for this episode. So again, everything's going to be at phenotips.com. So thank you so much, everybody, for tuning in, and definitely look out for the next webinar. Again, that's going to be in February, and the topic is improving patient experience. So again, thank you so much, Dr. Shaw-Smith. You're such a wealth of knowledge with this. So, all right. Thank you for tuning in, everybody. We've really appreciated having you today.
Okay, bye.
Bye.